All right, I think we're recording. So I am here with you, Sean. This is our first video. Basically, the purpose of this is just to let people in the organization get a better sense of what we do at Carefor, the different programs, the different services. We're going to try and keep this to 15 minutes. So it's essentially just an overview of the different departments. So let's start with you. Who are you? What's your title? Where do you work?
Well, my name is Sean, as you said, last name Sudbrink. Typically, I work out of the Belfast office, but I bounce back and forth between here and Carling from time to time as well. So within the city of Ottawa, within the confines of the city of Ottawa. And what do I do? It depends on the day. So typically, I oversee the visit and shift nursing program. And under that comes also foot care. So what do we do? What kind of services do we provide?
So if I'm an uncle at a barbecue and you're like, what do you do there at Carefor? What is your program? I know nothing about anything. Tell me in like, I don't know, 100 words or less. What do you do?
Provide support, direction, and guidance to nurses in the field who are providing care to our clients in the community setting. So that's kind of a lot broader than it sounds. In that I have to follow a fair bit of direction from our college, from professional practice standards, best practice guidelines. So there's a whole bunch of things. I by trade am a nurse. I by education and my degree was in nursing. One of my degrees was in nursing, I should say. And that's what I've worked at the past 25 years. So I'm bringing something different to the table because I've not been familiar with community before.
Right.
Because I've come from an acute care setting. Like the bulk of my career, 24 years of it has been in an acute care setting.
So let's talk about community nursing. So how does somebody come to receive care from Carefor? I know there's not a typical thing, but just what is sort of a normal way of somebody, getting a nurse from Carefor?
It's typically a referral process. The bulk of our clientele come from what was formerly known as the LHIN, now called HCCSS, an abbreviation for a whole load of words. Anyway, it's a community. So what happens is we typically get referrals. We have two streams. It could be either from the LHIN or from private. Typically, our private is very low. The volume of private clientele we have is quite low. And the vast majority, when I say majority, 95% would be from what was formerly known as the LHIN. So these clients could come from direct referrals to the LHIN from physicians, from hospital admissions, revisited clients. Sometimes clients have chronic conditions, and we see a fair bit of that, where clients come on service or off service and then come back on just because of the nature of their comorbidities or their disease process. So someone who's got these challenging disease processes that inhibits their ability to heal or warrants the need for nursing care, we see a fair few of those clientele.
So the people, like you talk a little bit about those people, like what would make somebody be more appropriate for community nursing versus other forms, going to their doctor, doing whatever? Like, why would somebody get home care nursing support?
Mainly for the maintenance. And so I'll just back up a little bit, Trevor, and the goal, just to tell you what the goal of home care is to act as a support and bridge, but ultimately to get someone to a point where they're sustainable on their own and able to do as much as possible for themselves with the support network they have in place. Some clients don't necessarily have the best support networks, or some of our patients don't. So it kind of doesn't lend to it. And those clients tend to be on service a little bit longer because of not having that, the much appreciated, that resource kind of thing, for whether it's in the form of family, friends, so on and so forth. There's a lot of pardon the expression of the term, there's a lot of people who are sometimes orphaned, for lack of a better term. When it comes to healthcare, we see it a lot, orphaned in the form of not having a physician, or orphaned in the form of not having a support net. So those two things really do impact a lot of our clientele. So to get to the goal of getting people sustainable and as functional on their own as is acceptable and possible, we provide care in the interim. And it's not just providing care, part of it is providing a teaching opportunity. A lot of the times people have new disease process that they're not really familiar how to navigate, how to deal with, what to look for, things like that. Part of our role as community health nurses is to teach them and their family, this is the best way to manage, or this is what we found works best from our practice guidelines and from our experience. And here's how you go about doing it. So we set them up with the appropriate amount of visits. We teach as much as we can, engage them as much as we can, because the goal of engaging families and engaging clients in their own care is they're a lot more invested in what's going on. They have a better understanding, and their outcomes are going to be much, much better. There's a huge body of evidence out there, literature out there on that engaging people in their own cares is the best means by which to make it sustainable, ongoing.
So is there, I mean, there's no typical, but I'm going to ask if there's a typical, like, are there certain situations you see more frequently? Is there a certain period of time? I know with allied health, it's often 4 visits. I mean, it's sort of until they get to that place. Like, how do you identify that they've gotten to that place? And again, like, what kind of situations are you often dealing with?
Well, that's a great question, Trevor. Actually, if we look at the nursing care delivery, we can kind of look at it from 3 different streams or 3 different pathways. One being wound management, another being generalized nursing, and another being palliative nursing. So if I were to divide it up and see how many were in each one, wound nursing tends to be the slightly higher volume. So we get a fair few number of people. About 60% of our clientele would be wound-based or have a wound at some point in time. About 40 to 45% then would be palliative. And then the general nursing there would be an overlap between both palliative and wound care for general nursing, because oftentimes people have multiple issues that they need addressed. So say, for example, the wound client may also be on antibiotics, which would be more of a general nursing, but they're getting both at that time until the antibiotics are over, and then the wound care continues.
Okay. So for somebody to come into our care, we're not the only organization in the community that offers these supports, correct? Like,
Correct.
there are other agencies that do it. How is it determined that somebody would receive service from Carefor? And what makes us different than any other organization that might provide similar services?
Oh, another great question, actually.
Another double question for you.
No, that's a good question, actually. I like that question. I like it because I get to plug how good we are.
That's it. That's why I asked the question. There you go. Softball.
Yeah. So one piece with the referrals that we receive, as I was telling you, 95% of our referrals come from what was formerly known as the LIN. So they send these out based on offer volume to each SPO or service provider organization. I apologize if I use some of these acronyms, but I'll try to explain them the best I can. If you were to speak to what was formerly known as the LIN, now HCCSS, they'd refer to all of the organizations who provide care as SPOs, which is service provider organizations, and everyone has an equitable market share. So what they do is they send offers out based on who has received which offers. So say if SPO A received 20 offers, then SPO B would then receive the next 20, this kind of thing. It goes on down the line, and it's done so in the most equitable way they can do it, to make sure everyone gets their fair market share of offers. So typically what happens then, it comes through intake, we accept or not accept depending on our capacity, because that's something that does happen from time to time, particularly during the events of the past 16 months. Of course, it's been a little bit on the challenging side from time to time with the volume of offers compared to what we can accept to make it safe to be able to deliver care. So once we accept, then they're set up, or the client is set up through an intake process, and the needed visits are then established. And the first step would be then, of course, to have the visit nurse go out, visit the client, spend a designated amount of time depending on what their needs are, but also to gather information. That first visit is going to be your history, your physical, your assessment, your medication reconciliation. It's kind of a paper-laden kind of visit, for lack of a better term, but also an opportunity to provide a point of care as well for the needed care.
Okay.
That
So
about as clear as
then,
mud.
that's
So
good.
then,
No, that's good. It's good.
yeah.
It's a good walkthrough. Then, so
So
what
makes
about
us different,
Carefor?
and what about
Exactly.
Carefor makes us different? Well, we were born from the VON, and if you were to mention VON, I think anywhere in the country, anyone over the age of 35, hands down, would unquestionably know what it is. But a lot of younger people still know, because it still has a presence throughout the country, just not in our area right now. So we, when we were established, I think it was about 15 years back when we branched off, we took over what was VON at the time. VON had always been, and always still, pride themselves in the best quality of care, like quality first, quantity down the road somewhere kind of thing. More about quality, and always focus on quality. Now, how do you achieve that quality? What we do differently, I think we do differently, is the amount of education we offer our staff to keep them up to speed on best practice. We reinvest in our staff on a regular basis, which is not always easy in community for a couple of reasons, because everyone's kind of siloed in the community setting. Like you're part of a team, but you're part of a disjoint team. Like you've got one here, one there, kind of all over the place. And to coordinate and to get everyone together for group events is a little bit challenging. So we've had to come up with creative ways to do it differently. So we have smaller groups, smaller education sessions, which is more costly, but very valuable, because it's more intense when you have a smaller group, and you get the opportunity to address concerns immediately. Whereas in a larger group, people tend not to ask as many questions if you have a large classroom group. So we offer an enormous amount of education, reinvesting back into our staff, of course, to make sure they're up to speed. We have 3 supervisors who, on a daily basis, their week would look like, if you looked at their calendar, they're typically out seeing our staff members on a daily basis, 2 to 3 staff some days. Per week, they'd see at least 5 staff members, visiting them in the field, going over changes in procedures, anything new they wanted to learn, any education plans they've been working on with them. So the support is phenomenal, and getting more and more back into out in the field with the supervisors has been very helpful, actually. Initially, when I had started here, it wasn't a regular routine thing. It was kind of put on a back burner just because of the structure and the way, they didn't have a manager prior to, so a lot of them had to pick up a lot of my role. So it's and they love getting out there with the staff, because they're very hands-on. And it keeps them up to speed, which is once again beneficial, because it comes across when we have meetings, when we have team times. We typically have team times a couple of times a week, and staff are a lot more engaged when they know that their supervisor is very versed in what's going on and up to speed and fully engaged. So it all comes back to engagement. Client engagement, very important for the education piece and for sustainability. Staff engagement, enormous. If you have engaged staff, you have staff who tend to love what they do and tend to be focused on what they do, and want to excel at what they do. So this this is why I think we're a bit different, because I think we focus on that part of staff development. So if I were to look at a new staff member coming on, we kind of have for lack of a better term, a 2-year plan for someone brand new. So someone fresh out of nursing coming in, typically or historically coming into community fresh out of nursing wasn't always the best idea. So what we've done was we've extended the orientation period, one, to offer them the added support. We've also enlisted in following this kind of 2-year plan. So what is their trajectory of education going on, going into the community setting kind of thing, coming into this arena? So they start out in their first 6 months. There's a fair bit of a big learning curve, huge learning curve, because it's often very different from what people would be used to. Care delivery mode in community tends to be. I was quite shocked by it. I had never been used to it. I was trained when I did my degree, we were either going to be academia, or community health nurses. So it's not that I'm that removed from it, because my training lent to it, but I was shocked at how much we do in community, which is very nice to see.
Right. So, okay. So community and community visit nursing and whatnot, different than staffing, clinics. How? Same, different? What's,
So do you mean like in a clinic setting as opposed to
yeah, home care? I mean, is it essentially the same concept, just in a different environment? Like, I mean, obviously providing care in somebody's home is going to have different realities than somebody, not receiving that care in their home.
Yeah,
How do we
no,
operate in the
absolutely.
different environments?
Yeah, for sure. It is absolutely. So the goal is to provide the same type of care and the same needed care as you would in the home environment, because there's not really anything we do in clinic that we wouldn't do in the home setting as well. The environment changes, obviously. So the big impact is like our environmental controls here in a clinic setting is quite different than they would be in a home setting, for a couple of reasons. One is we have available resources. We have colleagues here you can call on, and supply chain is never a problem in the community, or sorry, in the clinic setting. Whereas in the home setting, some of the challenges are, making sure your clients have all the supplies they need for the care needed.
Right.
That's something that's like it's been off. Typically, they do get it done right. They do a very good job, but there are times when there's going to be hiccups and roadblocks, to that, like weather can impact, or supply chain from our supplier, which is OMS. I mean, if they get hit with a low supply because of pandemic times, when it comes to PPE, something as simple as that can really have a downstream effect that impacts the point of care. So that's one of the challenges that's one of the bigger differences I would see in between clinic and community. Okay.
Is there anything, last question, anything that I missed? Anything that you think people should know about nursing?
Well, nursing has, in my lifetime, nursing has changed an awful lot. The focus of community has changed a fair bit. When I say the focus, I mean, I shouldn't say the focus. I think the care delivery in community has changed quite a bit. Yeah. In the past 15 years in particular, there's been an enormous shift in what can be done in community. Part and parcel of it being because of the realization that hospitals aren't necessarily the best place to keep people. Right. And hospital stays. The goal is that you go into a hospital, get done what needs to be done, then get out in the comfort of your own home, or come back and forth to a clinic setting, and we'll continue your care and get you to a point where you can sustain yourself. Right. So a lot of things have changed with regards to how much is done in community, like chemotherapy is done in community. We do chip disconnects. We do enormous dressings, some things that are, I'm going to throw some words out. This one in particular, it's called a Claggett's window. It's where your two hands can go inside of someone's chest cavity where their lung is removed. Yeah.
You do that in somebody's house?
We do this in their house. Yeah. You'd be floored at some of the things we do. We do vac dressings. We do advanced skilled debridements. It's phenomenal how much people don't realize how much we do in community. Yeah.
That's crazy.
Chest tube management. It is. Wow. It is. There's a huge paradigm shift when it comes to what can be done in community and what had been done in community in the past. Historically,
Yeah.
people refer to or think of nurses as, oh, they're coming to give my nighttime care or bed
Right.
care. We rarely do any of that anymore. Our focus tends to be very task oriented when it comes to skill set. You know, when it comes to dressings, IVs, and starting IVs, we do MAID cases in community. We do these all like regularly, like it's not an uncommon thing. I'm not sure if you've heard of the MAID cases, medical assistance in dying in the.
Oh yeah.
Yeah. Like we go out and we start the IVs and we assist in the whole process.
Wow.
Yeah, so
That's
it's remarkable how much is done in community, and it's only going to get bigger and bigger as hospitals. Hospitals are very they're very much needed, but they're needed for the very acute stage. Then sustainability and the duration of healing that's needed, much of it can be done at home, in the comfort of your home, or come back and forth to a clinic setting. So
wow, that's amazing.
Yeah.
Well, thank you, Sean. That was educational for me, and I hope it was educational for other people. Appreciate your time. Keep up the awesome work, you and the entire nursing staff.
Thank you, Trevor. Much appreciated. Thanks for letting me come on here and give us a plug that we much deserve.
Anytime.